Good afternoon, everyone. It's the first day of SCCT. Everybody's hungry, so we have some lunch here. My name is Ron Blankstein. I'm from Brigham and Women's Hospital. It's my pleasure to chair this satellite symposium, which is being sponsored by Caristo Diagnostics. We're going to talk about visualizing coronary inflammation and coronary CTA, the next frontier for cardiovascular risk prediction. We have really a terrific lineup of 3 talks. They won't be too long because we want to leave some time for Q&A. We're talking about a really exciting new technology, and I know everybody wants to learn more about it. So yes, we'll try to teach you about it, but I think the best part sometimes is hearing some of the Q&A, and all questions are fair game. So I'll get started with the first talk, which is coronary inflammation and cardiovascular disease prevention. As many of you may know, I am someone who loves CT, but I'm also a preventive cardiologist, and I specifically have developed an interest in why some individuals develop myocardial infarction at a young age. This is specifically a slide showing my research team, so these are not actual patients who had MI at a young age, this is my research team. And we've looked into the question at a large registry in Boston, looking at why individuals develop MI at a young age. And we've done over 20 studies to date, and I won't go through them, but I'll tell you that one of the striking things is that most individuals who have an MI at a young age, if you go back and you calculate their risk, it's low. So most of them are not eligible for statins. In fact, when you look in our registry, which is one of the largest registries to have examined this, how often are patients actually on statins before their MI? The answer is 12%. I mean, that's just an unbelievable number. But if you then dive deeper and you say individuals who have an MI, are these events that are happening out of the blue? And the answer is no. Almost all these individuals have underlying risk factors, often though they're not recognized. And some of these are traditional risk factors that we all know, smoking and hypertension and diabetes. But some of them are risk factors that haven't always been recognized. And one of the important ones is inflammation, specifically patients who have increased inflammation or systemic inflammatory diseases. In fact, coronary inflammation now has really reemerged because we now have studies showing that when you lower inflammation, you can improve cardiovascular events. So this was seen in a high-risk secondary prevention population in the CANTOS trial. My colleague at Brigham and Women's, Paul Redker, ran this, where the use of canakinumab was associated with a reduction in events. Similarly, with colchicine, a much cheaper medicine in patients with recent MI or patients with stable CAD, the use of colchicine has been associated with a lower event rate. But yet, I may ask how many people who are in the room who are cardiologists are using colchicine. I think that the number is probably very low. So we have some hands up. Some people are starting to use colchicine. And I think some of the criticism of all these trials is that the efficacy is pretty modest. The benefit is relatively small. And part of this may be because these trials are done in unselected populations. Not all of them have elevated inflammation. And even if you look at a systemic marker like CRP, that tells you that there's inflammation in the body, but it's not always specific to inflammation in the heart. So of course, the big question is, can we actually tell which patients have coronary inflammation? But here we are at SCCT, and I think the first question that often we ask is, can cardiac CT identify at-risk young individuals? I just started sharing with you information that a lot of patients can have an MI at a young age. Can we use CT to identify them? And the answer is yes, if we can find plaque. And in fact, multiple population studies have shown that the presence of any plaque in young individuals is associated with a higher event rate. So if you're looking at any scan, someone who's young who has plaque, that should always set up a red flag. But what about young patients that don't have plaque? So here's an example. A 33-year-old male with juvenile rheumatoid arthritis, no risk factors, a CRP less than 1. He actually presented to a preventive cardiology clinic, has a coronary CTA that has no plaque or stenosis, but we sent his coronary CT study to Caristo for a Phi analysis, fat attenuation analysis, and Harris will review this in much more detail in the next talk. But I'll show you that his Phi score, which is at the bottom left here, is at the 98th percentile. So his level of inflammation for his age, very, very high. We'll talk more later about some of this color coding, but the yellow is less inflammation, and red is a Hounsfield unit that has more water content and more inflammation. But certainly, this is a patient that if I have this data, and this is not yet FDA approved in the US, we can talk about this, but if we have this data that this patient has a high level of inflammation, would we treat him differently? And I would say that I certainly would based on what we know today. Now, so that was a young patient. What about patients that actually have coronary disease, patients who are actually at risk? We know that statin therapy is a good start, but it only reduces risk by 30%, meaning that the glass is still 70% full. So I think one of the things we're trying to do in preventive cardiology these days is to say, what else can we do beyond just statins? And you can see on this slide many agents that are now used in secondary prevention. And the big question is, who are the primary prevention patients who have a high enough risk that we want to give them some of these secondary prevention agents? And the question again is, can fat attenuation index help at identifying who has residual risk? So on this slide, I'm showing you two patients from my institution, and I picked this because they both have the same age, and it turns out that they have the same amount of plaque, okay? So everybody's gonna have to guess who has more inflammation in their coronaries. The 63-year-old male who has asthma, who has EGPA, which is what used to be called Sturg-Strauss, or on the right side, the 63-year-old male who has HIV, diabetes, and CKD. So on the left, who thinks that the person with asthma and EGPA has more inflammation? And on the right, who thinks the patient with HIV, diabetes, and CKD will have more inflammation? I think the patient on the right got more votes, but I think it was pretty split, so we weren't really sure. So if I show you now the Phi information for both of these patients, the patient on the left was asthma and EGPA. When we do his Phi score, it is at the 95th percentile, so very, very high. And accordingly also, this is a risk score that looks at his risk of fatal cardiac events in the next 8 years, also very high for this patient. And on the other hand, the 63-year-old male was HIV, which certainly is a condition that's associated with inflammation, diabetes, CKD. For him, the Phi score only puts him around the 50th percentile for his age. You can see here around the coronary arteries, the color map here, mostly yellow, which is not a high level of inflammation, suggesting that he's actually being appropriately treated. He doesn't have much residual inflammatory risk. So I think very telling that we have two individuals, same age, same amount of plaque. One was significantly more inflammation than the other. So the next question I would ask, well, can this score, and you're about to hear a whole lot more about this score, can it actually improve with anti-inflammatory therapy? And this is a very telling case from our institution. And I would say none of these cases were used clinically, but this is an area that we're very interested in. And specifically, this is a 45-year-old female with rheumatoid arthritis. On the left is her coronary CTA from 2019, and the right is the CA from 2022. And what we can see is in 2019, she was at the 83rd percentile. She subsequently was actually treated with aspirin, statins, and also a TNF inhibitor, which is a biologic agent that lowers inflammation. And now the Phi score for her is at the 17th percentile. So we see a significant reduction in coronary inflammation as assessed by Phi with the use of anti-inflammatory therapy. So what is the future of prevention? First of all, healthy lifestyle at all ages. That's always the starting point. Second, I think the whole field of prevention is moving towards earlier treatment. But earlier treatment will also require us to have better algorithms and risk scores in imaging to tell us who are the individuals that have enough risk that we should start treating them in their 30s and 40s. The next thing is that even in patients who have known disease, that have known plaque, we need to identify and treat residual risk. in imaging, both looking at plaque burden and also looking at inflammation, will help us identify who are those patients that can benefit from these secondary prevention therapies. And of course, we don't want to give these therapies to everyone because they are expensive and some of them can be toxic. So we need to have precision when we decide who to treat, and this is really the hope and the excitement about Phi. So that's it for my talk. For the next talk, we will turn over to Harris Antoniades, who is from Oxford, who really pioneered a lot of the scientific work behind the fat attenuation index. It really knows more about this than I think any person in the universe. And we'll turn on to you, Harris.
Thank you, Ron. Thank you for the introduction. Let me, it must be this one. Good, great. So I'm Harris Antoniades. I'm a professor of cardiovascular medicine in Oxford. These are my disclosures. My most significant one related with this talk is that I'm a founder, shareholder, and chief scientific officer of Caristo. And the technology behind the company comes from my lab in Oxford. Now, following Ron's presentation, I think it became very clear that it's extremely important to be able to measure inflammation in the coronary arteries in a non-invasive way, because in that way you can guide management and possibly prevent heart attacks in patients that you have no other way to predict whether they are going to develop any cardiac event. Now, I like to show this cartoon because it illustrates exactly the biology behind perivascular adipose tissue and its interaction with the vascular wall. When you have an inflamed artery, you cannot see the inflamed artery itself using cardiac CT. But what you can see the consequences of inflammation coming from the vascular wall diffusing into the perivascular space, because the adipocytes in the perivascular fat, they activate lipolysis. This is from the basic science. They get smaller, fat-free, and you have a shift of the composition of the perivascular fat towards the aqueous phase. If you treat a patient with an anti-inflammatory agent, then this reverses without even seeing any changes in the arterial wall itself. This can happen in the presence or in the absence of a plaque in the area. Now, perivascular fat phenotyping tells you if a plaque is inflamed, if there is a plaque in the area, or more importantly, if an artery is inflamed even before you see any plaque, because in that way, you can treat these patients if you are able to see these changes in the perivascular fat and prevent plaque development from the beginning. Now, we developed this method that is called fat attenuation indexing that uses standard coronary CT angiograms, brings to the surface this hidden information from around the coronary arteries, and it separates, it identifies the inflamed arteries from the non-inflamed arteries. And it's important here to understand that this is not only visual representation of inflammation. You can quantify these changes in the perivascular space by using the fat attenuation index, which is a measurement of attenuation around the arteries, but taking into account the three-dimensional gradients, how attenuation changes around the inflamed artery. Now, it's important here to understand that the fat attenuation index includes multiple corrections for technical factors, and it needs standardization to be reproducible. And this is one of the biggest problems of measuring attenuation in any kind of setting in cardiac CT. The fat attenuation index cutoffs in Hans-V units can be used in research, and this is what we did originally when we developed the method, and it can work very well in multivariable models, but when you want to come down to the patient, then that's where this is not really particularly useful. It's affected by technical factors, anatomical factors, biological factors, etc. So what do we need? We need standardization. In the when you measure fat attenuation index in the CCTA study in 4,000 patients, 2,000 patients from Cleveland Clinic, 2,000 patients from Erlangen, from Germany, there was a striking prognostic value if you measure this fat attenuation index, especially showing that increased inflammation in the coronary arteries, measured using this method, was related with between 5 and 9 times higher risk for a fatal cardiac event over the next 10 years, and also a 5 times higher risk for non-fatal cardiac event during the same period of time. When you combine these now with the presence of high-risk plaque, like low attenuation plaque, then it becomes very clear that when you have both, and that's a purple line, then you are at extremely high risk for a fatal cardiac event. If now you have high inflammation in the coronary arteries, but no high-risk plaque, you are still at risk to develop a cardiac event, and that's the blue line. If you have high-risk plaque but no inflammation, then this plaque that you see there is probably not that high risk, and you will not have an event most likely. Now, fat attenuation index, as I said, is a good research tool, but is it useful in clinical practice? Is it standardized? Is it reproducible? Can we interpret it? So a medical device that's developed based on this work, that is called Cardiovascular, does exactly this, takes these fat attenuation index maps, it corrects the values for age and gender, it takes into account the scan parameters, technical corrections, it applies some biological corrections that are introduced based on the biopsies of a few thousand biopsies of adipose tissue that we used in these algorithms. And it uses vessel-specific calculation algorithms to calculate what Ron mentioned earlier, the fat attenuation index score, the phi score. That's important to be interpreted in nomograms for age and gender, because in that way you can tell whether the artery is inflamed or not compared to the patient's peers of the same age and gender. Then the same device has a third readout, which is called Cardiovascular risk score, and essentially provides you the absolute risk of the patient for a fatal cardiac event over the next 8 years, taking into account the fat attenuation index, the risk factors, and the information about the plaque. Now, how can we interpret the phi score? As I said, you need to interpret it in nomograms, because in that way you take into account all the corrections that need to be taken into account so that it becomes clinically useful. And this is exactly what the regulators that provided the clearance for use in clinical practice in Europe, UK, and Australia request. They request standardization so that it is reproducible for the patient. Now, how do you interpret the values? If an artery is sitting above the 50th percentile, then the patient has 2 times higher risk to develop a fatal cardiac event. If it sits above the 75th percentile, then the risk goes to 2.4. And if it sits above the 90th percentile, then you are at 3 or 5 or even more times higher risk for a fatal cardiac event. And this is important to understand that it's the relative risk. So this is the risk attributed specifically to inflammation, and it does not take into account the risk coming from any other risk factors, genetic factors, etc. This is the residual inflammatory risk that is treatable with anti-inflammatory treatments. Now, how do we interpret the Cardiovascular risk score, the absolute risk prediction? So this takes into account the inflammation, and it also takes into account the presence of plaque and the risk factors of the patient. And it generates an equivalent to the ESC score that we have in Europe, but take into account this information, additional information from the CT scans. And based on this, we realize that we are currently under-treating 16.2% of the population having cardiac CT scans. So 16.2% of the population is not receiving the appropriate medication, and there is no way to know that this patient is not receiving the appropriate medication unless you measure this kind of inflammatory burden. Now, in the UK, this technology is now used in clinical practice, is used extensively in the private sector, but it's also now funded to be used within the NHS, by the British government, and it's deployed in the first 4 NHS trusts for real-world evaluation. This is how it works. The patient has the scan, the data transferred to the Caristo servers. You get the analysis for inflammation. You get the quantitative and the visual interpretation of inflammation in the coronary arteries. You get information about the plaque, low attenuation plaque, calcified plaque, etc., and the absolute risk for a fatal cardiac event. This information is then put onto a report and is sent back to the clinician, and we are now evaluating how this changes the decision-making process in primary and secondary prevention. Now, how reliable can absolute risk prediction be? We have these big cohorts that provide data for calculation of the ESC score or the Q risk. Do we have enough data sets to provide this kind of robustness and information? We do have this data, and in the orphan study, we include now 250,000 patients who had coronary CT angiograms as part of clinical care, and these are linked with 15 years outcomes from national registries. 200,000 of these patients come from the UK, where we have extensive collection of outcomes data from the NHS, and 50,000 patients from the rest of the world. Just to give you an idea, we have analyzed this so far, the first 65,000 patients, and during the follow-up, we have more than 700 STEM events, more than 1,700 non-STEM events, and so on. So we will report the first results from the first 100,000 patients end of this year, beginning of next year. So I will leave it here with the message that risk prediction using AI interpretation of coronary CT angiography is here and is here to stay. Thank you.
Excellent, thank you. Before our next speaker, just a quick announcement that apparently we have a lost phone somewhere. So if anyone is missing their phone, it'll be here. It's a nice phone. Looks like an iPhone 12. So next speaker, Dr. Milan Desai. He's a professor of medicine at the Cleveland Clinic and director there of clinical operations, and he will talk about implementing the CARI heart in clinical practice, a case-based approach.
Good afternoon, and thank you very much. Thank you all for attending. I think this feels like a culmination and a beginning of something that we started a few years ago, starting with Stefan Neubauer and us having a conversation, and he connected the dots. We are here, and I'm also truly thankful for the collaboration, not only with Oxford, but University of Erlangen. Mohammed is here, Stefan, etc. So how do we connect all the dots? And that's essentially what my role is. So as Haris has insinuated, basically, what are some of the things that we get from this new technology, from this report? So obviously the FAI score, which is the individualized quantification of inflammation. So we are moving beyond stenosis, plaque, into inflammation in the perivascular space. And it creates adjusted for age and gender, it gives you percentile values of relative risk. Then you are moving on to the CARI heart risk, the absolute risk of a fatal event. So it's not just enough to look at a nasty looking plaque and feel bad about it. This puts in context of what the risk of a future event is at the next 8 years. And so what is fat attenuation index? It's an unadjusted visual representation of the extent of coronary inflammation in these epicardial vessels. So putting all the things in perspective, and we will talk about individual cases, this is a standard report that this generates. So who benefits from a CARI heart analysis? People with ostensibly normal coronary arteries, because sometimes you have to dig deeper to get to the bottom of the problem. So people who have normal coronary arteries on conventional CTA, or people with mild to moderate CAD. The ones with advanced CAD, theoretically you're gonna treat them aggressively anyway, but as we are gonna show, the added layer of inflammation knowledge could also be helpful. So what are some of the questions? in the normal CAD population, do you need treatment? If your FAI score, as Harris had insinuated, if it is greater than 75th percentile, then you may need systemic treatment. More than 17% identified as high risk. If your score is less than 75th percentile, then lifestyle measures indicated. In the context of mild to moderate CAD, how aggressive do you need to be? So if your score, again, is greater than 75th percentile, then you need to escalate the treatment and maximize beyond what meets the eye. If it is less than 75th percentile, then you can theoretically continue at the same level of treatment. So meaningful impact on clinical decision making. These are heavy words, right? We need data, and Harris has shown outcomes data. So you have somebody with a clinically indicated coronary CT angiogram, somebody, hang on, okay, backspace, there you go. So somebody with no CAD, and you proceed with an FAI score. If it is less than 75th percentile, lifestyle, everybody needs lifestyle modifications. Little cookie here and there is okay, but at the end of the day, we need to be watching what we eat and exercise. 75th percentile, but less than 90th percentile in LAD-RCA, you need to start intensifying treatment. Greater than 90th percentile, you need to be potentially considering anti-inflammatory therapy. Of course, this is a concept that the last concept needs to be proven in randomized trials. So the reality is people with more than 75th percentile, 29% do not have elevated cholesterol, and 17% have ostensibly normal-looking coronaries and are not diabetic and no significant cholesterol issues. So let's go through some examples. This is a 56-year-old female, non-diabetic, normotensive. LDL is 66. You can't get much better than that. Pooled cohort equation is 2.3%. And for the astute readers, this is a CT meeting after all. So the coronaries look pretty much okay. Vast majority of us would agree, and there's not much to be done. Management based on conventional CTA, lifestyle measures. Then you get your Cari heart report. Yellow is okay, red is Houston, we have a problem, and blue is code blue. It is a little advanced level of badness. So this person, the FAI score was about in the 93rd percentile at 9.8, and the 8-year risk is the 3.8%. So in a 56-year-old, otherwise healthy female, this is a problem, I would imagine. Vast majority of 56-year-old females would think this is a problem. And the good thing about this is you get the personalized where your risk lies in terms of percentile, age, and gender match for every individual artery, epicardial artery. So in this person, one could recommend treating with aggressive cholesterol therapy, statin therapy in this scenario. High-risk Black, but low-risk patient, appropriately titled. Let's go through why that is. 71-year-old female, non-diabetic, normotensive, again, LDL is 64. Equation is 16%, so slightly more challenging. The person has issues. Patient's already on a statin, and as you can see in the LAD, there is a not so happy looking mixed plaque very proximally. So based on conventional management strategies, what would you do? If there's not much for me to do, I would say let's increase the statin dose. This person, again, underwent Cari heart assessment. The FAI score was 10.8, putting it in the 40th percentile Cari heart risk at 1.4% at 8 years. Compare that to the first case that we talked about. and they lie nicely within the lower spectrum of the risk percentiles. So in this person, the atorvastatin dose was left unchanged. Having said that, if this person's cholesterol was 130, nobody is going to leave them unchanged. But beyond at 64, based on the additional analysis of inflammation, one can make an argument that we are not doing too bad. So, serial heart analysis. 46-year-old female in 2012. Of course, the technology didn't exist in 2012, so we are going to work our way through this. So 2012, 46-year-old male, non-diabetic, normotensive, started rosuvastatin 10 milligrams after CT angiography. There was mild non-calcified plaque noted. 2016, appearance is unchanged. Patient is complaining about muscle spasm, muscle cramps, what have you, not uncommon. So rosuvastatin was stopped. The doctor got sucked into the emotional drama and said, let's stop the rosuvastatin. CT angio looks okay. 2021, CT angio, again, appearance is unchanged. And at this time now we have Harris and his persuasive waves, so we have now ordered a carry heart analysis on everyone. So the first scenario, 7.8%, putting it in the 90th more than 90th percentile, 1.4% 8-year risk. Now, we are at 5.5 carry risk and 0.7% 8-year risk. So doing okay, not too shabby. But at this point of time, rosuvastatin is stopped. The non-invasive coronary angiogram, the way we look at it, looked exactly the same, but the inflammation has changed. Now the numbers are increased to 10.5 and a 2% risk. So this technology is detecting changes in risk that are not captured by plaque. In this context, Crestor, rosuvastatin 20 milligrams was reinstituted. Now, on the flip side, so where you are going to encounter a lot of patients with extensive disease. So 76-year-old male, hypertensive, non-diabetic, well-controlled LDL, cohort equation 14.7%, and the calcium score is 768 and is on atorvastatin. So what do we need to do? This patient, basically, most of it is yellow on the analysis. The risk is in the 11th percentile, 7.4, and the carry heart risk is 3.4% risk of a major event at 8 years follow-up. And if you look at the dots, they are in the lower spectrum of percentile risk. So this person, despite having maximum disease, given the fact that your cholesterol is well controlled, one can feel good about continuing what you're doing. System is working. Don't mess with it. High-risk patients despite minimal disease. So this is another scenario, 56-year-old female, non-diabetic, 68, cohort equation of 79%, atorvastatin 10 milligrams. So currently, looking at the current state of the affairs, we would say no change in treatment. This person's score was 99th percentile and 81.6% risk within 8 years. This patient died of an anterior MI 33 months after CCTA. And you can see there's a lot of code blue on the analysis. And the dots here are through the chart in terms of their risk prediction. So with that, I will stop, and I think we should have some. I'm assuming there will be plenty of questions. Thank you so much for attending.
Thank you, Milind. Really interesting cases. We're going to open it up to questions. This is very easy. If you want to ask a question, you just raise your hand and a mic magically will appear in front of you. You don't even have to walk up to the mic. So we have one here, but until the mic makes it to you, which will just be in a second, also was a simple, maybe not so simple question to Harris. There's a lot of excitement out there about the ability to look at inflammation on coronary CT. And I've certainly heard people say, well, why can't I just, on my own workstation, draw a region of interest? Why can't Sam Wan, who's here in the audience, draw a region of interest and look at that attenuation and see what's going on? Or even visually, I know some says, oh, that's like fat stranding. Can't you just see that visually? Why do we need a fancy software when you can just draw your own ROIs?
Yes, very good question, Ron. Is it working? Yeah, very good question. So it's important to understand that Huntsville unit measurements of attenuation around arteries are a good research tool when you use it into multivariable regression models in research. But when you come down to the individual patient, it's meaningless. The absolute values of attenuation is a meaningless reading for the patient because, for example, if you have an obese individual with larger adipocytes to start with, then a very negative value could imply inflammation despite the fact that it doesn't reach the cutoff that was described in the CRISP-CT study, which was a minus 70.1 Huntsville units. While a lean individual with a less negative value, let's say minus 65 Huntsville units, could be absolutely normal, and it's not at risk for a heart attack, simply because the adipocytes were small to start with, and you have not taken into account the gradients, and you have not taken into account the corrections that need to be taken into account to have a meaningful reading required by the regulators as well.
Okay, great. No, that's very, very helpful. I think we have one there, and then we'll get here, and then three. Yes.
So what's the correlation between inflammation and plaque volume? Because plaque volume appears to be prognostic also in risk of myocardial infarction.
I think that's a great question. I think we're talking a lot about plaque volume. Are these separate axes, plaque volume and inflammation, or are we looking at the same thing? I'll turn to also Harris and Milind.
Yeah, I can start. So we have done these studies. There is a significant correlation between the low attenuation plaque volume and the fat attenuation index, but the correlation coefficient is at the range of 0.3 to 0.4. So they are not identical. They don't mean the same thing. They are complementary when you use both, and this is what the device does. It takes into account both the plaque volume and the fat attenuation index, and this is how it achieves this high performance in predicting risk. If you have high plaque volume, which is not inflamed, then the risk of the patient is very low. And this is why the correlation coefficients are not, they don't show collinearity, they show a good correlation.
Exactly. I couldn't have said it any better. It's synergistic. They are on top of each other. So, and the way I look at this is certain things you can look at, meaning the plaque volume, you can ascertain, measure, but like Harris said, not all large plaque volume is inflamed, and this is where a tool like this adds incremental value, synergistic value.
I'll say in risk assessment models, even after you account for plaque volume, if you add inflammation on top of that, the discrimination of the model improves. So there's basically incremental predictive value when we combine the two. But I think it's a very good question. We'll turn it over here.
Mahfouz Shahawi, Sarasota, Florida. This is an area which we have been having interest in, the epicardial fat, for the last 10 years, and we did already some studies, quantitative analysis. Have you correlated the epicardial fat volume with your fat attenuation index? That's the question number one. Number two, there have been recently some data out on publication about semaglutide reduce the epicardial fat. So in case if you have that, you don't need to go to anti-inflammatory drug with all side effect. So have you correlated, because the fat volume, that's what makes the difference?
Yeah, again, very good question. So
The
if-
epicardial fat volume was your fat attenuation
Yeah.
index. Because if you have epicardial fat volume increased, we did quantify it. Then you have all the index and all the risk factor and all the carotid intimacy, pulse wave, and everything, and calcium score goes high up. So you don't need to go further.
So epicardial adipose tissue volume is indeed an excellent measure of obesity,
Yeah,
So
have you
that's
been
of
able to
metabolically-
measure
yeah.
it here?
of metabolically unhealthy obesity. In the CRISP-CT study, and in all the other studies that I have presented data for, if you look into all the regression models, epicardial adipose tissue was always there. So any effect that we observed is on top of risk factors and epicardial adipose tissue volume as the gold standard for measuring obesity. And it's important to separate the two, the quantity from the quality. We have the quantity of the adipose tissue and we have the quality of the adipose tissue. They are both important, but they give different information. Specifically for the fat attenuation index, within the depot of epicardial adipose tissue, you see gradients of attenuation as you come close to the inflamed artery. You don't care about what is happening beyond the 2 centimeters away from the vascular wall. You are interested on all the changes happening within a few millimeters around the vascular wall if you want to extract information about inflammation. And this is complementary and in addition to the information you get from the volume of epicardial adipose tissue, which is an index of obesity.
In connection with that, we did study the obesity. We divided in 2 types of obesity. Obesity, which increase your visceral fat without increase of your epicardial fat, and the other one with increase. And there was a day and night difference as far the risk index and other changes, the calcium score, etc.
I'm going to turn to another question. Or was there another comment? If not, I'll turn to the next question. Yep.
Thanks for the great presentation. Just I have a question. I'm Dea Hakim from Brigham and Women's Hospital. There are a number of studies now studying especially using the intravascular imaging, studying the preemptive PCI for the plaque with high-risk features, but not encroaching on the lumen. But it seems that like if we add inflammation to this plaque, it's going to double the risk. So like at this moment, what would be the most important factor for such plaque is to start with anti-inflammatory or fixing the high-risk features.
Are you referring to NIRS imaging?
NIRS and the OCT and the prospect too,
Yeah.
they have this in the NIRS imaging, yeah, NIRS IVUS.
So that's an important question. As a non-invasive cardiologist, my initial bias would be rather than going invasively, going at it with a catheter. Before that, we should be developing robust tools of non-invasively addressing this medication-wise. And the comment I'm going to make addresses both of your situation. I think, the fact that now we have a robust tool that can measure. So does it have the accuracy? Yes. Does it have the reproducibility? Yes. Does it have the potential for incremental prognostic utility? Yes. Has it been validated in more than one population? Yes. So now one can say there is a robust endpoint tool, and if we develop therapeutic strategies where this can be used as an imaging endpoint, as a surrogate endpoint in addition to events, I think sky's the limit for developing not just broad anti-inflammatory therapies, but precision, semaglutide, for example, or precision therapies specifically targeting coronary inflammation. Why systemic inflammation? But to answer your question shortly, I'd prefer something non-invasive before going at it based on an invasive catheter.
And I agree. I think the key is there's actually terrific invasive approaches. They don't always measure inflammation, so you'd have to do a head-to-head comparison. But I think that the promise of evaluating high-risk plaques, not just high-risk plaques, I think it's all about the high-risk patients when we look at all these scores. I think that's what's going to drive long-term therapies and improve outcomes, but good question. I'm going to ask another question, and that is related to, like, what are the patients who are going to be ideal for this? As I see all the cases that Milind showed, cases I showed, you know, we're all trying to figure out who are the patients who are going to be most appropriate. We have here in the audience Dr. Fontanes, who's one of the leading cardiologists in the U.S. Army. So he sees a lot of young individuals in the U.S. Army, and he's trying to identify which ones of them are at risk, even though they have a normal coronary CTA or a calcium score of 0. So he's wondering, can I apply this to low risk? Next time we have Dr. Thomas in Indiana. He's seeing high-risk patients in his practice, and he's saying, well, can I use this to patients who already have plaque? I'm already treating them with statins. They're already on semaglutide. Can I use it in that patient population? What is really going to be the patient population where this is going to have kind of the killer indication?
If this were a board question or a board answer, you know, is there a choice of all of the above? Perhaps, you know, again, look, medicine and choice of imaging is always going to be a nuanced approach. But as we have discussed, you know, in something that looks normal to the naked eye, is there action happening in the wall? And the data makes a compelling argument that there could be action happening in the wall, which may improve with preventative therapies. On the flip side, so that's the normal looking. Clearly, most of us would agree that the lowest hanging fruit is somebody with mild non-obstructive CAD, because you know there is already action, and assuming this person is youngish, then the sooner we jump on that, the better off we will be. And we, you know, there's 17 to 20% people in whom the numbers don't add up, and this may add definite incremental value. Now, the flip side, the highest branch to get to for the fruit would be somebody with established disease. And one may say, you need to treat this person appropriately anyway. Why do you need to look for trouble? Now, often, many of these patients will come to your office worried sick about, what, doc, I got this. Am I gonna be able to see my grandchild's wedding in 5 years, 7 years? You know, this could theoretically help redefine their risk and maybe bring them down from the ledge that they may be on. So, you know, again, all these things have to be validated in broader clinical experience. But I think I would say all of the above.
Okay, so all of the above. That's always, when in doubt on a test, always circle all of the above, but I think it really is applicable here. Did I see Sam's hand go up? So Pat, what is?
Yeah. Yeah.
I can give you my experience in a couple of cases, but Harris will know.
Yeah, so we do have data on that. There is a good correlation with the readouts from PET. Sodium fluoride PET, for example, has a very good correlation coefficient with what you measure around the coronary arteries. Correlation coefficients range between 0.5 and 0.7, depending on the population you look at. So it touches collinearity. It's not exactly the same thing, because with sodium fluoride PET you measure microcalcification, which is a good index of active inflammation, but it depends on the type of inflammation you try to measure. So there is a good correlation between the two, but this is routine CT angiography. You don't need to have fancy technology. You don't need to apply an expensive test like PET, and you get information that is very comparable.
And resolution. Sam, resolution is also a major player here. PET is good for a cardiac level, but not at a coronary level, not at a
So I think those answers were related to sodium fluoride, and knowing Sam, he was probably thinking about coronary flow reserve in impairment of flow. Was it more, if it's related to that, I'll tell you that the case I showed of the young woman was rheumatoid arthritis that had profound inflammation. She also had abnormalities in blood flow reserve. So I bet the two are different axes, but there's a lot of association there, because we know coronary inflammation would lead to impairment in blood flow reserve as well. So I bet there's a lot to that. But the key is this could be added on top of the coronary CTA much cheaper and get a lot of information, but obviously a good area for future work. We're actually out of time. I see some more hands of folks can come
Sorry
up.
with the. Sorry, I was waiting for like half an hour.
Who's that?
Raising. Hello?
Yeah.
Here.
Oh, was a mic. I was like, where's that guy?
Yeah.
Yeah, sure.
So I just
You're actually waiting for a whole hour. We've been here for an hour.
Yeah,
So.
no, half an hour. I wanted to ask the reproducibility and significance when you do it on non-contrast CT, on CT or photon capture CT. What's the reproducibility and significance between three CTs?
Yeah. So just a quick answer. The method is trained and developed on coronary CT angiograms. You need contrast to perform the analysis. And this is for a number of technical reasons, but also for biological reasons, because you capture the variability and the density of the microvessels inside the fat. So there are a number of technical reasons and biological reasons why it has to be done on contrast CT. Photon counting CT, we'll tell you in a couple of months. We have a photon counting CT scanner, which is in a hybrid cath lab in Oxford, and we are running these studies now. So we'll have the answer before Christmas. Yeah, you can measure attenuation around arteries with contrast, without contrast. You can measure attenuation anywhere in the body. The question is, what does it mean?
So with that, thank you all. Really, thank you to the speakers. This is a really exciting area. I think we're going to see a lot more in the future coming from this for risk assessment and assessing inflammation. So stay tuned, a lot more in this area.